Hello, my name is Casey Johnson, and I'm currently a student in the MSN FMP program, presenting today the examination of pediatric blood level screening rates in the primary care setting. Here's the complete poster view of what we're going to be discussing today. Let's take a few moments and discuss the individual categories and their importance. Lead exposure at any age can cause long-lasting negative effects for those exposed. The pediatric population is particularly at high risk for lead level exposure and toxicity due to the developmental stages that they're obtaining at the time. The pediatric cohort for this is 12 months to 6 years of age. With their developing mind, they are at high risk for irreversible neurological damage in both acute and chronic lead exposures, which can lead to development of ADHD, ADD, decreased brain volume as an adult, poor academic performance, and increased risk of criminal behavior as an adult. For ADD and ADHD, 1 out of every 5 childhood diagnoses of ADHD is directly related to lead level exposure. And according to the American Academy of Pediatrics, children in this cohort have lost approximately 23 million IQ points due to lead level exposure. The lead level exposure that causes these different neurological deficits are those that are 5 micrograms per deciliter or greater, according to the CDC. The American Academy of Pediatrics states that approximately 2.6% of children aged 1 to 5 years have a blood level higher than the reference lab, which equates to 535,000 children. Common sources of lead exposures include contaminated water supply, household paint, pottery with lead glaze, herbal remedies, imported cosmetics, and imported candies. For the contaminated water supply, that's the drinking water lines that are coming into your home. The importance of having those removed or having lines made of different substances was very evident in the Flint water crisis. During that time, their lines are primarily made up of lead, and the exposure rate was increased by 36% in the pediatric population. For household paint over the last 4 decades, we've made major strides in decreasing the concentration of lead in those paints, therefore decreasing the exposure risk. The concentration of paint has been reduced to 90 parts per million, and that has been since 1978, and that's why when you go for a house, that's something that has to be expressed if the home has had their paint tested if the home is older or built before 1978. As well as we have unleaded our gasoline. To mitigate these risks and identify exposures, the CDC has passed guidelines to govern the screening intervals at 12 months, 24 months, and at least one time before they're 6 years of age if not previously screened. Children, however, that are receiving Medicaid benefits are mandated to obtain this at 12 months and 24 months and at least one time before they're 6 years old. The objective of this study was to examine in the primary care setting if pediatric patients less than 6 years of age, if they're obtaining the blood level screenings in comparison to the national screening average of 18.7%. The method used for this study was a quantitative retrospective chart review. The chart review is focused on the following ICD-10 codes: ICD-10Z 13.88, R 78.71, a CPT code of 83655, and CPT of 36416. The inclusion criteria for this study consisted of 50 pediatric patients. They were aged 12 months to 6 years old. 25 of the charts had to have listed their primary insurance as Medicaid or RKID, and the other 25 charts were listed as their primary insurance as commercial or private pay. Exclusion criteria for this study was any child over 6 years of age. The findings for this study in this particular primary care clinic, the screening rate for Medicaid patients that met inclusion criteria was 0%. The screening rate for commercial, insured, and private pay pediatric patients was 0%. The national average screening rate is 18.7%. Arkansas does not mandate universal screening for all patients within the cohort through formal regulations. Arkansas only requires screening to be in compliance with Medicaid requirements. However, it does not mandate reporting for screening compliance to the CDC. For an action plan following this study would be a study that evaluates for obstacles hindering compliance and provider opinions over the blood level screening is suggested. According to Deloy, Marquez, and Gernsberg, compliance rates of physicians surveyed within their study only indicated 40% compliant with the CDC recommendations. Obstacles that they stated was by the physicians was confusion over the different recommendations, lack of state mandate, and belief that screening for asymptomatic patients is not needed. Physicians that possessed a high compliance rate stated it directly relates to parent-patient education, in-house screening, and staying cognizant of the current recommendations. I'd like to take this time to acknowledge the work of Dr. Chris Jordan, my mentor through Arkansas State University, as well as Ms. Leah Privet, my clinical instructor at Arkansas State University, for their hard work and dedication. References are as listed. Thank you for your time.